Thank you for attending this evening. We're quite excited, actually. The LPC has been working for quite a long time now. We were actually presented with a model of working with Change, Grow, Live about 2-3 years ago, and we decided to wait and let CGL fine tune it. So when we were renegotiating the new contract, we were really pleased to see they've been listening to the partners they've been working with over the last couple of years, and they've really come up with a class-leading, I think, model for working with those patients that, as we know, are most vulnerable. So really pleased to have with us this evening Kulvinder from CGL, Change, Grow, Live, who's our key partner for our methadone patients in Reading. We have 29 pharmacies in Reading, 22 of which are signed up to the current contract. And wow, we've got over 30 people now, which is really, really good. So please welcome Kulvinder. He's going to take you through the process of the new model, the sort of rationale behind it, how it all works, why we're sort of exploring new ways into helping our patients benefit from the real skill set of our community pharmacies. And there will be plenty of time for questions at the end. And one of the great things about this evening is that Kulvinder is going to take you through some live sort of demos of using the template. So when you're in your pharmacy, you can really sort of begin to understand how you can get the best out of the system. So Kulvinder, over to you.
Thank you very much, David. Good evening, all. Thank you for attending this session. I appreciate you're all very, very busy, and it's run up to Christmas as well. So again, thank you, and thank you for the great attendance as well. Thank you, David, as well, for supporting with this, and Kevin for supporting us from the LPC side. And we've got Lynn, who is the Change, Grow, Live manager at Reading, and also Chris on board. Lynn, if you want to introduce yourself, and Chris, if you're here as well.
Hi,
I can't see everybody's faces, so.
Hi, yeah, I'm Lynn Taylor. I'm the services manager for Change, Grow, Live, and we've got Chris and Jules here as well. Jules, most of you will probably know, but I'll let them introduce themselves.
Hi, I'm Jules. I'm the clinical prescribing administrator at Reading. I know a lot of you from when I've rung up and spoken to you.
Hi, and I'm Chris, and I'm the admin and data lead for the service.
Thank you.
Kulvinder, can I just take this opportunity just to let everyone know that we do have a new partnerships lead, Marta, who's starting next week, and she'll be taking on the key pharmacy liaison role. So she'll be making contact with everyone as soon as she starts.
Excellent. Yes, I forgot that one. Sorry, Lynn. So I'm Kulvinder. I am medicines management pharmacist at Change, Grow, Live, and today, this evening, I'll be talking briefly about how this new service, the new CoreMat service, came into being, what the initial evaluation has shown, and its launch in the Change, Grow, Live Reading service, and for you as community pharmacists in the Reading areas. Obviously, I know the LPC covers a larger area, so if there are any pharmacies that are not necessarily in Reading, but do provide services for Change, Grow, Live service users that are based in Reading, then please, you're also invited to sign up for the SLA as well. Myself, just as a brief introduction, I've been a pharmacist for many years. I like to remember. Initially worked in community pharmacy for multiples, independents as a locum. I've also been a contractor for many years, and I moved into substance misuse approximately 10 years ago, initially as a harm reduction lead, and then I became a prescriber some years ago, and I've been doing clinics, and then moved into this medicines management pharmacist role, but also still carry on doing clinics. So I appreciate the functions, and I can see things from all angles, from yourselves as community pharmacists within services, and see how we can meet in the middle to make new services work well in community pharmacies. So today, as I said, we'll be talking about the new CoreMat service. So the agenda today is looking at why we thought we needed to change, looking at the core mat service, its aims and its components, then looking at the individual components of the service, looking at the fee structure, training and assurance, and then sometimes questions, feedback, and then right at the end, or however you want to do it, I can do the templates that are going to be used from PharmOutcomes. We can do that after the training, or we can do the questions after the training. It's entirely up to you, but we can discuss that at the end. As I say, we'll talk about how the service came into being, talk about how it was evaluated and its development and the next steps in Reading. So why change? Obviously, supervised consumption has been around for many years, and we appreciate that it hasn't changed much over time. And community pharmacy teams play a vital role for us within substance misuse in providing care and support to people using substance misuse services, primarily through dispensing of medication, but also through supervised consumption. As an organisation, Change Grow Live recognise that supervised consumption hasn't changed much over the years, but healthcare and particularly the community pharmacy setting has changed a lot, particularly over the last few years. And also the needs of our service users have changed as well over the time. We're aware as an organisation of the multiple challenges that community pharmacy face, and we're in regular contact with OHID where we raise these issues around community pharmacy concerns, particularly around the number of community pharmacies and those that are closing at the moment and limited in opening hours, etc., over the last few years, particularly since COVID. And we wanted to, as an organisation, to do things better. So this is when we began looking at an alternative commission service, which has started looking at this roughly 2 to 3 years ago, that we wanted to utilise the pharmacy skill mix better, improve service user safety, and offer an independent healthcare professional-led intervention through community pharmacies. But to do this within a standardised framework across our organisation, that would also improve efficiencies and quality for both pharmacy teams and also Change Grow Live services. This new core mat service has been developed jointly with Change Grow Live, the LPCs, community pharmacists themselves, and partnership agencies such as our local commissioners that commission substance misuse services in areas, and also the PharmOutcomes team. So we developed the framework. It was trialled commencing April 2023 in 6 areas, and an evaluation exercise has been undertaken. So I'll share some of those results with you guys today as well. And the pilot sites covered both rural and urban conurbations, areas of depravity and areas that are more affluent, and coastal areas and inland areas. So we had a good mix of coverage across our organisation. Post-evaluation, we're looking to launch this service now across all of our organisation in conjunction with LPCs and local community pharmacies across our services. As I say, it hasn't changed much in terms of supervised consumption. The issue with supervised consumption is only approximately 30% of service users are actually on a supervised dose. So within the supervised consumption SLA, they are the only ones that are entitled to a pharmacy-led intervention. The remaining 70% are not contractually obliged to have a pharmacy-led intervention. But we know that in community pharmacy teams are supporting all service users, irrespective of whether they're on a supervised dose or a non-supervised dose, on a daily basis. And we can only consider this to be, as community pharmacies do a lot of things through goodwill. And there's no way to measure what support was being offered. And also, there was no way we weren't remunerating for that support that you guys were providing. And that in itself introduced variation in terms of how we were remunerating community pharmacies, but also variations in how we were treating our own service users, because those that were on a supervised dose could have an enhanced service through community pharmacies, whilst those that weren't could not have that enhanced support. That's something that we wanted to address. And also over the years, pharmacists, pharmacy contractors, LPCs have raised concerns around remuneration, and for the current service not being remunerated enough, and also along with the changes in the community pharmacy capacity and availability, we recognise that a change was needed, and a change was needed urgently. So the core mat aims are to provide a holistic approach to enhance the health and well-being of individuals affected by drugs, to manage the risks such as drug-related deaths, overdose, and other threats to health, and to provide this within a quality-driven, standardized framework. It's about providing equity to all service users, irrespective of whether they're on supervised or non-supervised dose, and to improve the efficiencies in the reporting and recording of activity through community pharmacies, as well as the quality of information that we're receiving so we can act on that information. It's also to enhance service user safety through a holistic approach, and to pay pharmacies more for the work that you guys are doing at the moment and encourage maximum engagement with service users with the service. So the components of the service are wellbeing support, reporting all missed and late dose notifications, supervised consumption, and an annual review by the pharmacist. And I'll talk about each of these components further as we go into the presentation, and also look at what some of the evaluation results found. So the pilot sites were 6 pilot sites, covering East and West Sussex, Cambridgeshire, Peterborough, Norfolk, and West Kent. Where we provide Change Grow Life provide the service substance misuse services. It covered approximately 5,000 service users, which represents 5% of all service users in structured treatment, and it utilised over 540 pharmacies. So in April this year, this has further been expanded to another 3 services. So we're now covering 10,000 service users across 1,000 pharmacies, and now across 9 pilot sites. Well, they're not pilot sites now, so they're standard sites now. But in the initial 6 pilot site evaluation, we retained all pharmacies that were previously signed up to the supervised consumption SLA with the new core mat SLA. 5%, there was a 5% increase in the number of pharmacies participating in the new core mat service, which was a great result, because the issue we were having in April 2023 was pharmacy closures, pharmacy mergers, short-term pharmacy closings, and this, just to maintain the numbers and increase, was justification itself for changing the service for us, because we were struggling to find pharmacies that would accept our cohort of patients. Obviously, because this new service now covers all service users, irrespective of whether they're on a supervised dose, there was an extra 3,600 service users that were able to have a pharmacist-based intervention. And the average CGL monthly spend for this service, in comparison to the supervised consumption scheme, went from approximately £6,000 to £10,000. So that's a 66% increase in the revenue that would be similarly seen through to community pharmacies themselves. There was reduced time spent by pharmacy teams trying to contact services, whether that be via telephone, via email, or via a single point of contact through PharmOutcomes. And there was a 50% reduction in the processing of missed and late dose notifications by our own admin teams. Over 1,000 pharmacist reviews were completed in that time as well. So just in terms of community pharmacy engagement benefits, as I say, we increased the number of pharmacies engaged with this scheme as against the previous supervised consumption scheme from 515 to 540. We retained all the previous pharmacies that were engaged with supervised consumption into the new core mat service, and we increased by a further 25 at the time, as a net increase of 5%. And the value of the local community pharmacy liaison was vital for the launch of this service, as it will be in Reading as well. So we will have a dedicated person that will support you guys in implementing the new service, answering any questions that you have with regards to the new service. So you've got a single point of contact. And that's the most important thing that we found, and one of the most important things that community pharmacists and their pharmacy teams valued, in being able to have a direct point of contact to maintain relationships at all time, and with the LPCs, because there's nothing worse than when we get it reported back to us that I spoke to so-and-so, but nothing happened. So that's why we've got dedicated roles within the majority of our services now that are there for specifically for community pharmacy engagement. So the first component of the core mat service is the wellbeing support, which is available at the request of a service user and provided by any trained member of the pharmacy team. And it involves giving advice around healthy living, signposting, referring, safeguarding, and more specific harm minimization advice. Obviously, the latter ones are part of the standard NHS contract anyway, to provide signposting and healthy living advice. The more specifics of harm minimization advice is looking at bloodborne virus awareness, safe injecting, overdose prevention, safe storage of medication. And if any pharmacy or any pharmacy teams don't feel they're confident to provide that advice, we can support you, we can put on training. Please let us know if there's any specific training that you would like around this. And that's something that as a local team, we can look and support to increase staff awareness so they can confidently give that advice. I know substance misuse it is a bit of a niche market, and particularly substance misuse advice that we give across pharmacies can be frightening for people that haven't necessarily had the adequate training. So if there is that training that you require, please let us know, and we can provide that training as and when you require it. And by the way, this whole presentation can be considered as part of your CPD as well, if you want to write it down as your CPD. So the second component of the CallMat service is the reporting of missed and late dose notifications. We base our treatment plans on risk. Substance misuse treatment is different to, say, for example, treating blood pressure, treating cholesterol. There are a lot more risks involved. As I said, we base our treatment plans around risk. So when you see prescribers, when you see key workers, everything is around risk and mitigating risk. We accept that people use drugs. You're not going to move away from that. Our aim is to stabilize service users on their MAP medication, so they're not risking putting themselves at any risk by using any illicit drug use on top. And adherence is an issue across all healthcare. The World Health Organization predicts adherence to be around about the 50% mark. In substance misuse services, there is no real data on adherence. And this brings an added risk, because if somebody's not adhering to their medication, then it's not like if you miss a blood pressure tablet or you miss your cholesterol tablet. It's more of a long-term issue. But with substance misuse, if you're not taking your MAP medication, you will be searching for an alternative to replace that MAP medication. Otherwise, you will be at risk of withdrawals. And that's where the risk comes in, because there's a risk of people falling off prescriptions, the risk of people disengaging with the service. And obviously, when somebody's been in treatment for a while and they're stabilized and they then return to illicit drug use, there is the risk of overdose, because there's a reduction and change in tolerance. At the moment, we've got the issue with the new synthetic opioids, which are manufactured in laboratories, and very little is known about them, except for the potencies are, for example, with some of the nitazines, which are the new synthetic opioids that have been manufactured in labs, and they're quite easy to manufacture. They're over 500 times more potent than a heroin bag would be. So you can see the risk that service users are exposing themselves to if they don't engage with their MAP medication. So this is why we wanted to get some information and start creating a picture around a service user's actual engagement with their treatment. And this is where the reporting of missed and late dose notifications comes in. When will report these notifications via PharmOutcomes, they'll come directly to us within services. And from that, the key worker will be alerted, and we will then proactively engage with service users to prevent them from falling off prescription, to see if there's anything that's going on, to see if there's any extra support that they need. And in all of this, it enhances the service user safety. And over time, we've had concerns in the past from OHID, we've had concerns from coroners, where this communication is not there between community pharmacies and services. And it's not something that we've specifically asked for over the years as well. Some of our Change Grow Live services do have reporting of missed doses, but the actual reporting is haphazard. So we wanted to make it more concrete, and we wanted to then, therefore, from that information, support service users where we can see there's issues with their collections, but also start looking at some research to see if there's any variation between what they are prescribed and what their adherence is, whether it's a daily pickup has a different adherence to whether somebody's unsupervised, or whether somebody's on a weekly pickup has a better adherence than somebody's not on a weekly pickup. So that's where this the reasoning behind the missed and late dose notifications come from. So this is the template that you will see. All of our reporting is all done through PharmOutcomes. We work very closely with PharmOutcomes on this, and each template has gone through reviews with LPCs and the pilot site community pharmacies as well. So it's been developed in conjunction with pharmacist requests and ease of use. So it's a very easy method to report. It's selecting the service user, selecting the medicine type, and then the breakdown of the medication, whether it's, for example, if it's buprenorphine, whether it's a Subutex brand or the Espranol brand, and then selecting whether it's a missed collection. For example, if somebody's missed their dose today, that will be reported as a missed dose today. And then selecting when you last dispensed to the client. If it's a late collection, that is for people that are on installments that are not daily. So, for example, if somebody's on a Monday, Wednesday, Friday pickup, and they don't pick up their Wednesday dose, so you would report that as a missed dose, but then also report the date when they actually do come in to collect it as well. So if they come tomorrow, then you'd select tomorrow as the late collection date. This provides us with that information on adherence. And in the evaluation of the pilot sites, we had a doubling of the number of pharmacies that were engaged with actually physically reporting missed and late dose notifications. In 4 of the pilot sites, we saw between a 475 to 800% increase in the number of missed and late dose notifications. And in 2 of the pilot sites, where there was a previous well-established mechanism to report missed and late doses, we still saw a 20% increase in the reporting of those missed and late dose notifications. And I say at the first time, this includes all service users, irrespective of whether they're supervised or not supervised. And as I said, there was direct reporting. So whenever a pharmacy reports a missed or a late dose notification through PharmOutcomes, it comes directly through to our live service, and it's uploaded to the service user's case record, and then the relevant team, the relevant key worker is notified. So it's actual live data that we're getting now, which we've never, no substance misuse service has ever had live data of where somebody is with their treatment. And you can see how the benefits of this are there for us to know where a service user actually is within their treatment. Normally, for example, in reviews, I will ask a service user, are they collecting their medication regularly, and they'll give me an answer. I will normally then call the pharmacy up and get us. Normally, it's pretty much the same. Sometimes we do find some anomalies, but generally it is pretty much the same. But this will be giving us actual live, accurate data of where we are with a particular service user, and then that will be expanded to all service users within a particular Change Grow Live service, such as Change Grow Live in Reading. Previously, in terms of reporting missed and late dose notifications, there's a variety of methods that are used across our organisation. Some pharmacies will be calling the local service, and I know how difficult it is for you to get a response. Some pharmacies will be emailing, and some pharmacies there wasn't a request from the local Change Grow Live service for missed and late dose notification to be reported, which I think we had something similar to that in Reading at the moment. I've just been doing a little evaluation on Hertfordshire, where we launched a service in April this year, and we've seen a similar findings to what we found in the evaluation. They've had a 700% increase in the number of missed and late dose notifications being reported. They did have a reporting mechanism via PharmOutcomes prior to the CoreMat service, but it wasn't used. But now within the embeddedness of this CoreMat service, we're seeing some real numbers, and it's a large service, so you can see where people actually are with their treatment. So the third component of the CoreMat service is a supervised scheme. Obviously, supervised consumption remains the core of the scheme. It's still there. We still need it. It protects people, particularly vulnerable people, in terms of initially into treatment, or where there's any risk or any changes or any concerns or any safeguarding. That's where supervised consumption comes in. And we listen to feedback from our community pharmacy colleagues, and there were concerns because our SLA for supervised consumption mentioned that it should only be undertaken by a registered technician or a registered pharmacist. So we've listened to that, and obviously the changes in skill mix within community pharmacies, and all the developments in new services, to relieve the pressure off the technicians and the pharmacists within the teams. We've now opened it up so it can be undertaken by any trained and competent member of the dispensing team, as long as they are aware of the SOP and the SLA, and the pharmacist has deemed them to be competent. We've changed the whole reporting process for claiming supervised consumption fees, for example. We've removed the need for logging the 14-day prescription like you do on the old templates. And we've removed the need to actually then go in and declare whether somebody's collected on that particular day. It's now just a simple monthly declaration for all service users that are with you at the pharmacy to trigger the relevant activity payments. And it's all done it's a two-second job for each individual service user. And this is what most pharmacies have fed back as the ease of reporting and claiming payments at the end of the month for each individual service user. With this new CORMAT service, what you will need to do is re-register all of your service users. So obviously in the previous supervised consumption scheme, you register only those that are actually on a supervised dose to claim to then go in to log your supervised doses and to claim payment. They don't link together with PharmOutcomes. So PharmOutcomes, when they develop these new templates, advises that each new service user, or each service user, would need to be just re-registered once when you start this new service. And then that data will be transferable between reporting missed and late dose notifications, undertaking the annual pharmacist review, and doing your end of month claims. The registration template is the same. There's not much difference to it. We've removed some things such as GP addresses and whatnot. We've removed that. But what we do suggest that you do is you use the PDS, the personal demographic service on PharmOutcomes, to register the service user. Reason being is the PharmOutcomes system will be talking to our patient medication record within our Change Grow Live Reading service. And if you register manually with the previous template that I showed you, the issue that you have there is sometimes if you do any spelling mistakes, or if you do any short names or nicknames, the systems won't talk to each other. So to ensure there's 100% communication and accurate transfer of data between PharmOutcomes and our patient medication record, it's advisable to use the personal demographic service, because that's linked to the NHS, and we're linked to the NHS in that way as well. So if you can, when you're registering your new service users, then please use the PDS. So the registration templates are now open. They've been open since Monday. So if you log onto your PharmOutcomes account, you'll find under the CORMAT service patient registration. So if you can commence registering your service users using this system, then you'll be ready for it going live on Monday next week. So this is the template for claiming your monthly fees. As I say, this new CORMAT service is for all service users. So there's an activity fee of some sort for all service users. And you complete one of these templates for each service user that you have at the end of the month. And as it says here, you'll be selecting your provision date, the client, the drug type, and again on the right hand side you'll have the breakdown that will appear. You then select the month that you're claiming for on the drop down, and then you make a declaration whether somebody's supervised, and if they are supervised, a small drop down will come up to just total up the number of supervisions for that month, and you just add in the number there. There'll be a prompt to say, have you reported all missed and late dose collections? and then there'll be a declaration that somebody's been dispensed 10 days or more worth of MAT to trigger off the monthly activity fee for all service users. This is just shows it a bit more in detail. So obviously, if you click the service user is supervised, it will come up with this question about declaring the number of supervisions, and then where all missed and late dose collections reported is a prompt to remind you that they need to be reported. Now, this does not mean that report all of your missed and late dose collections at the end of the month. This is just a prompt to remind you that this is part of the scheme as well. If you select no for that, it will come up with this blue warning about missed and late dose notices. Please ensure all missed doses and late collections for this month have been reported. That is just a prompt. We do still get some pharmacies that are reporting at the end of the month, obviously, because when they do their monthly claims, this prompts, and then they start advising us of all the missed and late dose notifications. The missed and late dose notifications should be reported within 1 working day. And the reason why we ask for that is so that we can actively engage with the service user. So, for example, if you've got a service user that's missed 2 days and you're reporting at and that was at the beginning of the month, and you're reporting at the end of the month, the risk is at the beginning of the month, because on day 3 they fall off prescription. That's when the highest the highest risk of overdose and death through not being on a MAT prescription. To be on any dose of a MAT prescription, whether that's methadone, buprenorphine, is a lot more safer than them not being on any MAT. And that's the reason why this missed and late dose notifications will be implemented and acted on within services. So please report the missed and late dose notifications as they happen within 1 working day. Obviously, if it's on a Friday and you're closing the weekend, it will be on the Monday. That's to be expected. And the last tab is just declaring that you've dispensed 10 or more days to activate the monthly activity fee. In the initial pilot of the core MAT, we asked pharmacists to undertake quarterly reviews. So that was 4 reviews per year. And the feedback that we had from pharmacists was that it was burdensome on them with all the other services that were going on, the launch of Pharmacy First and other schemes, the COVID jabs. So the agreement that we had was that it will be changing to an annual pharmacist review. So this is undertaken by the pharmacist. It's a holistic based review undertaken in the consultation room, I'd say with the pharmacist. And it's to look at issues around adherence to their MAT medication, look at adherence to other medication that they may be taking, and a chance expert to highlight any possible contraindications or drug interactions, and to review with the service user that they have safe storage and they have naloxone availability. Naloxone is the antidote to opioids when there's an overdose. And the opportunity for the pharmacist to provide healthy living interventions, signposting and referring, because our service users do not readily access healthcare. As you'll be aware, I'm sure you've had many questions from them. They don't like going to hospitals because they have concerns about where their medication will come from. They don't like going to their GPs. Sometimes their life is chaotic, and looking after their own health is not the priority. And this is where this intervention from pharmacists has been proven to benefit service users greatly. And the last stage of the annual pharmacist review is the opportunity for the service user to ask the pharmacist any questions that they may have. So I say in the initial pilots, we were doing quarterly reviews, and over 1,000 reviews were undertaken, which represented roughly 20% of service users in the 5,000 cohort. As I said, the issue that pharmacists raised was it was burdensome for them to do it in a quarterly basis, and hence we've now gone to the annual review. 16% of service users reported adherence to prescribed medication from Change Grow Live service as an issue, and 12% of service users were on a suboptimal dose and using illicit drugs on top. So these two are the biggest flags for us. So in treatment, we obviously aim to get somebody on a script as soon as possible, for the service user to be adherent to that medication, and also to be on a dose that keeps them stable, so they're not experiencing withdrawals. We're managing their cravings for heroin, and there's no illicit drug use on top. And from that, we can then start doing the psychological work to look at why the drug use started, and just from there discuss reduction plans, etc. But until that person is on that stable dose, they're still going to be looking for illicit drugs, which hinders their progress with the psychosocial side of their treatment. Naloxone supply and referrals made on 109 occasions. As I say, with the current issue with the heroin drought and these new synthetic opioids, that's one of the most important things for us, because we're now issuing at least 2 naloxone kits to every service user because of the potency of these new synthetic opioids and how long they can last in the system. Healthy living advice was provided, including smoking cessation, diet, exercise advice, and particularly there was referrals being made to mental health and physical health concerns by community pharmacists for service users that they were engaged with their local mental health teams and their local GPs. And that is the essence of joint working for us. When it comes to service users' relationships with CGL, so generally with substance misuse services, there is sometimes still that apprehension. Some service users still see substance misuse services can be penalising if they make any declarations. And within the NHS, make every contact count, and also within different voices, different strategies, service users will declare things to community pharmacy colleagues that they necessarily won't declare to substance misuse services for fear of some penalties, which we don't put obstacles in ways of how we treat service users. But there is still that stigma that some people will have, and because obviously we treat based on risk, and obviously if something comes up that could be quite concerning, could be risky, then we would look sometimes at how we're providing their MAT medication, how often they're going to the chemist for their MAT medication. And that's something that a lot of services like to preserve, particularly like, for example, if they're on a weekly pickup and they're aware if they declare something to their worker or their prescriber, that might put that situation in peril. So they won't necessarily declare it to us, but they will declare it in general conversation. I'm sure you'll know in community pharmacies. I've got experiences in the past where people would declare quite openly to me in a community pharmacy, but they would never make that declaration, I don't think, in the substance misuse service. So this is what the annual pharmacist review looks at. So the first few questions are around consent. Obviously, it's consent for them to undergo the annual pharmacist review, and it's consent for them for that information to be shared. If a service user answers no to either of the first 2 questions, then you don't go ahead with the actual annual pharmacist review, obviously, because it's down to consent for that review to be undertaken, and also for that information to be shared, so we can then act on that information when it comes through to us in Change Grow Live service. So once this review is completed on the template on PharmOutcomes, again, same as the missed and late dose notifications, it will automatically come through to our Change Grow Live Reading service, and from that it will be uploaded to the service user's case management record. The prescriber will be alerted, and the key worker will be alerted for anything that needs to be addressed. Also, it will be raised in our local multidisciplinary team meetings. And I say the information that we're getting from these reviews is amazing. I'll talk to you in a moment about something we found out in the Hertfordshire evaluation when we come to it in a moment. So it looks at discussing with service users if they're allergic to any medication and documenting that, if they've suffered from any adverse drug reactions and documenting that. There is a tab on the template for you to access with the service user's consent, their summary care record. We ask you where possible to ensure that is done, because service users are not necessarily always on hand to have all their information available for what they are prescribed. We as services we're not part of the NHS, so we don't readily get access to GP summaries, summary care records. It takes time. We can get them, but and as community pharmacies, you have direct access to summary care records with service user consent. So where possible, if you can access the summary care record to get a bigger picture of what they're actually currently being prescribed, will be great. So that's the first stage. Next stage is looking at their MAP medication. So whether it's methadone, whether it's buprenorphine, looking at their adherence, seeing generally how they pick up on their prescriptions. You'll be aware of that generally, and discussing with the service user if there's any issues around their adherence, any hindrance to their adherence, how you guys can support their adherence, or how we in Change Live services can support their adherence. And then the next stage is looking at optimal dosing. So what we aim for in treatment is a methadone dose of between 60 to 120 milligrams of methadone and 12 to 16 milligrams of buprenorphine. These are the proven doses where there's optimal saturation of the opioid receptors in the body. So obviously, if the opioid receptors are not saturated, then still that chance of residual cravings for heroin and withdrawals appearing. So we aim for optimal dosing. For some people, this dose can be lower. It's not, but that's the standard that we aim for. And if they're not on that optimal dose, then that's something that we need to be looking at, especially if they are using illicit drugs on top, which is what the question asks for. Or, for example, the further question will be that if they're aren't using illicit drugs, are they stable on their suboptimal dose? And if there's any support they would like regarding their medication and dose. So that looks around their current MAP prescribed medication. We then go on to any other medication that they are taking. So this is where the summary care record comes in use. And we're asking the pharmacist to go through with the service user if they understand why they're taking the medication, and to document any advice that you give or any response that they give around that, and their adherence to that medication, and any support that you can provide or any information that you can provide to increase that adherence. The next stage is to look at contraindications and interactions, and in your professional opinion as pharmacists and medicines expert, if there are any contraindications between what they're taking, to document those, and if there are any interactions, to document those as well. The next stage is looking at safety around naloxone. So we provide all service users with a naloxone kit, if not more than one, with consent, and this prevents the risk of overdose. If a service user sees somebody, or anybody can have access to a naloxone kit. So, for example, community pharmacy teams can have access to naloxone kits. It's an injection. If anybody's in an overdose situation with opioids, then you administer the injection, similar to an EpiPen sort of style injection. And this acts as the antidote. For those services that provide naloxone from their pharmacies under an SLA, then they can provide that at that point to the service user, or they can be, if that provision is not available through your pharmacy, you can signpost them back to the CGL service or to another pharmacy, and that's documented in the review. And the same situation with safe storage. So we offer safe storage boxes to all of our service users to secure their MAP medication when they are at home. And if a service user doesn't have a safe storage box at home, then, and it's documented in the review, then you select to refer to the local CGL service, and we will follow that up once we get that review come through to us. The next stage is looking at healthy living advice. So asking the pharmacist to provide healthy living advice, offer pharmacy healthy living advice, should I say, and where necessary, signpost to whether that's any relevant pharmacy service within your pharmacy, for example, smoking cessation, or signposting to or referring to an additional service locally, and documenting what advice was given. And we've found that virtually every single service user has been offered some sort of healthy living intervention, which is great, because, as I say, our cohort don't always access healthcare services. So any advice, a small amount of information is a great deal for some, and that's a principle that we work on. And I said the last stage is for the services to discuss anything that they may want to discuss with the pharmacist, and utilize the pharmacist's skills and skill set within the community pharmacy team. that's it. That's the annual pharmacist review. Once that's completed, it's submitted on PharmOutcomes. As I say, that will come through to us, and that's for us to then implement anything that needs to be implemented from our side. And the more we do, the better it is. So every service user is entitled to an annual pharmacist review, irrespective of whether they're supervised or non-supervised. So please engage with this. You can plan it out within your pharmacy how you're going to do them. Some pharmacies we're seeing are doing them all in one go. Some pharmacies are spreading them out through the year. Obviously, we had COVID injections, so those pharmacies that were doing COVID injections, flu injections, we saw none over the last few months, and now they're picking up again, and they'll pick up again in January. So that's up to you guys how you actually do your reviews. But what we do request is that every service user that's in your pharmacy gets an annual pharmacist review, because the benefits of it are showing as being amazing. So this slide just shows the fees that we're paying for each component. So the core MAT offer is to cover the reporting of missed and late dose notifications for all service users, and for all the pharmacy team providing their wellbeing support advice. And then each completed annual MAT review is paid £30, and then you've got your individual supervised consumption fees, which are still there. So training and assurance, the training and declaration of competence on substance misuse is still there for pharmacists and registered technicians. That's every 3 years. As I say, we've changed the terming for who can actually supervise doses. So that's down to the pharmacist now to make that judgment. For any competent dispensary team member that is aware of the SOP and aware of the SLA can now undertake that supervision. And also within that, the reporting of missed and late dose notifications can be done by any member of the pharmacy team that knows how to use the system on PharmOutcomes. The annual pharmacist review must be only undertaken by the pharmacist in the consultation room. We'll be doing annual training events for the pharmacy team. So if there's anything particular that you want to be trained on, please let us know. At CGL Reading, we'll put that particular training on. There'll be an annual audit of this new service. And so we might ask you some questions and might ask for your feedback. And there's also, we'll be doing monthly monitoring of what comes from reportings on PharmOutcomes for the CGL Reading area. Investment wise, as I say, you've seen the 66% increase in spend that we've seen on average. In Hertfordshire last week, their spend has increased by near 70%. So obviously that's that 70% that you will be seeing in your individual pharmacy payments as well. So there's considerable investment, and we're keen that every aspect of this core MAT service is engaged with. So reporting of all missed and late dose notifications, supervised consumption, and also the wellbeing support, and finally that annual pharmacist review is completed. It's a sector first, this new service. So Change Grow Live is the only provider that is offering an alternative to supervised consumption across the substance misuse sector. There's a lot of commissioners here looking at it as well to see where it goes. So the better the results are, hopefully it will be leading to this being rolled out nationally as a more comprehensive safety-based service for substance misuse services through community pharmacies. All right. So this is some of the feedback that we've had from stakeholders during the evaluation in the 6 pilot sites. I think for me, the most important one is the humanizing of service users, really. And that's the feedback that a lot of service users have had, that somebody's actually taking interest in them. We can look at the actual live templates now, or we can do questions now. It's entirely up to you how you want to do this.
Go for it, Colvin. There's only been one question so far, and that's about having an easy flow chart, just to highlight what needs to be done daily, weekly, monthly, and annually with the new service. Yep. It's quite a good idea, actually. but the copy of the manual and the slideshow will be, well, it's already there actually. If you go to our website under the CGL bit, copies of that is there now, and a copy of this video will be posted there tomorrow.
Very nice, load it up. So this will appear different to your guys' templates as commissioners, as is slightly different. So in terms of the supervised consumption, registration, supervised consumption, supervision, these templates will be decommissioned as of the 2nd of December. So you won't be able to put any new entries on post 1st of December. They'll be unavailable for you to do that. Now, any supervisions that you haven't reported up until the end of November, you can do, because the actual templates will remain open for any entries prior to December for up until the end of February, because you have a 3-month window to report. So the templates will be available for you to report any supervised consumption claims up until the 30th of November, which will be open all the way up until February. But please get that on there sooner rather than later. So they will be open at the moment, but you won't be able to put any new entries on for supervised consumption claims post the 1st of December. The registration for all CGL MAC clients is already open. So that's the registration for all your new service users that are going to be opting for the core MAT service. So all of your current service users that you have at your pharmacy will need to be re-registered as a one-off on this template. So this is a template as I previously showed. So it's just name, date of birth, gender, etc., etc. But then on your tab, you'll also see the PDS here. So please register via the PDS where possible, if you've got the match. In terms of the missed and late dose notifications, this is how it looks like. So, for example, you'll pop in your service user name that you've already registered in the registration template, select the drug, there'll be the drop down for the type of drug, and then a missed collection. So if somebody's missed today's dose, for example, you'll log that on today, or if you're doing it tomorrow, select today's date. And then there's a entry there for when you last dispensed to the client. So for example, if you last dispensed on Tuesday, if they're on daily pickup, then you just pop that there. And there's an area for notes if you want to leave any notes. If somebody's on a late collection, so for example, somebody was meant to collect on Tuesday, you've reported it as a missed collection on Tuesday, but then they appear today, this is the date that they actually collected the late collection. So they missed their instalment on Tuesday, which was due on Tuesday, but they've appeared today, which is Wednesday. The prescription says you can provide it on days when the pharmacy is closed, or with the official Home Office wording about minus the number of days that they should have had in the instalment. You select the date of the actual late collection and select the date that you last dispensed, which let's just say will be Sunday, and then you submit that. That's how you report the missed and late collections. And then you've got the monthly supervised and unsupervised declaration. So that's at the end of the month when you're submitting your claims as you normally would. So it's your client name, again, selecting your drug, selecting the drug type, the month you're claiming. So for example, let's just say we're doing November. And if this particular service user is supervised, you'll tick yes, enter the total number of supervisions for the service user. So if Joe Bloggs had 15, you'd enter 15. And then were all missed doses or late collections reported? Yes. If you tick no, as I say, this sign will come up to remind you that to report all missed and late dose notifications. You've also got the declaration about dispensing 10 days or more worth of MAC medication to trigger the activity fee, and you tick yes for that. If you report, which we were finding initially similar to the old supervised consumption template, which used to be entering the 14-day prescription, What will happen is you'll record one person twice. This throws up an anomaly because you're reporting a person twice for the same medication. And what's happening is pharmacists will then report, for example, the person had 14 days of doses. Yes, you tick that, and 10 more days. And then they're submitting that. But then they're going in again to report the second prescription for the month. So 14 day done, the next 14 days starts, they're then popping that one in. That will be an incorrect way of claiming. We just want, for one service user, just one declaration per month per drug. And it does say that as a warning. It doesn't show it on here, but it will say it in red. Please declare one declaration per drug per service user. So it is a move away from the 14 days, because we're not doing the 14-day reporting as you did on the old template. And I can go into the old template if you'd like me to, and I can show you what I mean. But it's a complete move away from that. It's just a simple one-off declaration for each service user. You don't need to declare each time that you've supplied a prescription. So if you go into your old one or your current one that's inactive now in supervision, you're popping your client name, you're popping your methadone, for example, and then for each day you're saying whether it's supervised or not supervised, etc., etc. That's all been removed. There's no need to do any of that. It's just a single declaration. And the reason being is obviously you're doing all your declarations here. So your declarations are for every service user, irrespective of whether they're supervised or not supervised, because you've got an activity fee for all. So if you've got Joe Bloggs who is supervised, he'll be getting the supervised consumption claim here, and also the monthly activity fee here. If Joe Bloggs is not supervised, you'll be getting the activity fee anyway. So to make it simple and record it all on the same template, it's all within here. So hence, you don't need to write for each individual day whether they were supervised at all. You just need to make a declaration of this is the number of supervisions for that calendar month. I know if you get a prescription that goes over from one month to the next, it's from that particular month, not from the actual prescription. And then finally, you've got the annual pharmacist review, which again, it'll be slightly different to when you see it on your side. So client name, tick for consent, yes. Tick for consent to share, yes. And then you've got the SCR declaration. So that's a yes or a no. You can still carry on with the review. It's a decline to give consent to SCR. You just ask them the questions. There will be the SCR tab here for you to click on. That'll take you the link you through to summary care records. And again, so you've got your allergy declarations, you've got your adverse drug declarations, the current MAT adherence. Let's just say they're taking 12 milligrams. And then your discussion around MAT adherence, if they're adherent or not, and documenting any reasons, any issues, any concerns. Is there any support they would like to improve their MAT adherence? And again, documenting what information is given to you, and any information that you might provide to support that. For example, you might find that there's a service user that's taking their Subutex twice or buprenorphine twice a day, splitting the dose. You know, it's a single day, 24-hour preparation. So you could advise that there's no need to split the dose. It's a single day preparation. The questions on optimal MAT doses. So if they're not on an optimal MAT dose, the further breakdown questions will appear to see if they're using any illicit drugs. And it's a yes/no depression. If they're not, then if they're on a suboptimal dose but stable or on a reducing dose, and if there's any support that they would like regarding their MAT medication and dose. We found pharmacists have, in conversation with service users, just alluded to service users requesting an increase in dose, and that's something that we need to address as soon as possible. Some service users actually declared that they were feeling drowsy on their medication, which can be a sign of oversedation. And that was not clear to us within services. So that's the sort of information that pharmacists are getting out of service users that sometimes we weren't aware of. And then the next stage is look at their other medication, and you just type in here a drug, and a drop down will appear. So for example, we won't do Anadine because it's not allowed on prescription, but let's go to, it does bring a long list, but the more you type, the better it is. 500 milligram tablet. There you go. Let's go for that one. And then the dose, and again, make sure they're aware of why they're taking the medication, and documenting the advice or any information that's given to you, and checking their adherence and documenting any information. You can then, if that's the last drug that they're on, and you don't need to, you just tick no for the second medication. If there's more drugs, you can record up to 10 different drugs on this. And on average, we're seeing people on 2 to 3 drugs from the reviews that are being completed. The next stage is looking at contraindications, and if there's any contraindication that you feel in your professional opinion, then to document that. And if there's any drug interactions, to document that. The main interactions that we're seeing are increased drowsiness. For example, if somebody's prescribed pregabalin by the GP and they're also on methadone, or somebody's on citalopram or an SSRI, and then there's the risk of QT interval prolongation with methadone. That's been documented by pharmacists as well. So I think we did have a really interesting one. Somebody was prescribed morphine by the GP, and obviously by us. And within the opioid stewardess guidelines, there's 2 opioids going on. That's something that we normally are aware of that, but sometimes we're not, particularly if it's been commenced in hospital, and the surgeon hasn't had a review. So it's something that we can then pick up and liaise with the relevant prescribers. And so the next stage looks at naloxone, whether they've got a supply of naloxone, and also whether they've got a safe storage box. And then just know it's a referral to service. And then the last stage is asking about healthy living advice, documenting what advice you offered, and selecting if you referred to anywhere else or offered any relevant farm service, and detailing that as well. And then the last stage is the other issues, and then you submit that. As I say, this annual pharmacist review, along with the missed and late dose notifications, come to pharmacies, will come to the local CGL Reading service, a notification like this. So whatever you've populated up will come straight through, and it'll be listed like this into the service user's case management record. And then the relevant prescriber, key worker, and team will be going through this to see if there's anything that needs to be actioned, and we'll be implementing that action.
Great, thank you, Kulvinder.
Right.
We were overrunning slightly, so we can possibly fit in a couple of questions. We've got one from Mohammed in Basingstoke Road. Just difference between missed and late collection.
So a missed collection is a missed dose on that particular day. So whatever the relevant collection date is, if that date is missed, that will be recorded as a missed collection. So the late collections are for those that are not on daily pickups. So that's when we need to be notified of when they actually collected the instalment.
Brilliant, thank you. Anyone else with a question? No? Okay. Well, obviously, you know your CGL team really well anyway, and they're always going to... good question, Mohammed. The annual review, do we get told when? I presume when to do them?
No, service is going live on the 2nd. As I say, so start commencing your reporting of missed and late dose notifications from the 2nd, and your time to start doing your annual farm review starts on the 2nd. So you've got 12 months from the 2nd.
Yeah. LPC advice would be to plan them ahead, try to do so many per month.
We don't stipulate, because we know pharmacies, you've got your own capacity issues, so we don't say
absolutely
when. It's entirely up to you guys how you plan that.
Yeah, some good planning is needed, I think. Anyone else? So this is going to be new for everybody, but we have got a really great CGL team that you've worked with in the past. So please don't hesitate to pick up the phone, and I'm sure that they'll come and visit you personally anyway. And as will Kevin, I'm sure he'll schedule in some visits post-Christmas to see how you're getting on, see what we can learn from, what we can feedback back to Kulvinder and his team. Because this is new. It's still forming. It can be tweaked down the line when they get more sort of intelligence from pharmacies and your teams. But this is obviously done for the benefit of the patient, ultimately, for their health and well-being. And it's obviously really important we do look after those particularly vulnerable patients. Okay. Anything from anyone else before I close the meeting and press the stop button? Just want to
Lynn,
say thank you to Kulvinder and his team for their continued support. We do meet up with them very regularly for feedback and operational issues. And I must say, you know, we really work well together. So thank you for all your support.
I was
And
just going to say, David,
continue
does
to
anybody
work.
have any service CGL Reading specific questions that they want to ask? Once we've got Lynn and Chris here now.
Absolutely. And as Kulvinder highlighted earlier, this is a CGL first as well. So other service providers are looking at this with great interest. So those, you know, who also work with Cranston's and Turning Point, etc., this may be something similar to be working with in the next couple of years or so. You never know. So thank you very much, everybody. Thank you for your time this evening. Do late collections? One more question from Agita. Do late collections need to be reported daily?
Late collection. So whenever the person attends for that late collection, that's when it's reported.
Thank you.
Dave, can I just say, so the templates will be live on Monday. So we'll be going live on Monday. If you got your SLAs, please sign your SLAs and return them to Chris.
Yeah, if you want to get paid, return those SLAs.
Yes, then you'll be getting paid more. And also, any issues, please report to the local CGL Reading team, or please come back to me. PharmOutcomes will be transferring your accessibility. If you're on a current supervised consumption pharmacy, they'll be transferring you across to the core mat service as of the Monday as well. If you're not a current provider of supervised consumption and you're interested in core mat, please let us know, and then we'll open up the tabs for you guys as well.
Can
Fantastic.
I just add as well? So yeah, thank you, Kulvinder. We're learning too, so we'll probably be in touch with you with any any questions that we can't answer. But yeah, I just wanted to say as well, you know, just to thank you to all the pharmacies, because we really do appreciate the work that you do. It really does help, and this sounds fantastic. And you know, listening to the feedback from other services and the difference it's made in the treatment that we can provide is brilliant. So we are just about to look at the NSP, so the needle syringe program contracts as well. So they're coming over to you, David and Kevin, tomorrow.
Good.
So yeah, apologies for that. But if anyone is interested in who isn't currently providing the NSP contracts, then you know, we'll be doing something, aiming to do something similar with our providers, delivering some training for any of your staff that would like to learn more about NSP. So yeah, watch this space.
Brilliant. Thank you very much. Have a great evening, everybody.
Thank you.
And
thanks
speak to
everyone.
a lot of you soon.
Cheers.
Cheerio. Thank you, Kulvinder. Bye-bye.